Welcome to the CAA 2022 webinar series. Today's webinar is Aeromedical Retrieval Complexities, the Trauma Diamond, with presenter Eric Bauer and Q&A with Eric Bauer and Marty Nichols, proudly supported by Zoll. Thanks for joining us and please enjoy.
Hi, welcome to the latest of the Council of Ambulance Authorities webinar series. I'm David Waters and I'm the Chief Executive of the CAA. This webinar is proudly supported by Zoll, who we thank for their ongoing support. We will hear from Eric Bauer, President and Chief Executive Officer for Flightbridge ED. Eric also has in excess of 30 years experience in EMS and HEMS settings and is a recognized author, speaker and educator. You may have listened to Eric previously on one of his many critical care podcasts. Today, Eric will discuss the lethal trauma diamond, damage control resuscitation, and analyze the four components of the trauma diamond. Please join me in welcoming Eric. Thank you.
Everybody, welcome to this webinar. My name is Eric Bauer. I'm the founder of Flightbridge Ed and the Flightbridge Ed podcast. Been a paramedic and flight paramedic. I've been in the industry for 31 years. Excited to be able to present this topic. I currently live in the Kentucky area in the United States, and I hope you enjoy this lecture. Hey everybody, welcome to the Lethal Trauma Diamond. Let's get started. Objectives: we're going to define the lethal trauma diamond. We're going to discuss damage control resuscitation as it pertains to the four components of the trauma diamond and analyze a case study throughout this lecture and apply it to core pathophysiology. We all have seen through the evolution of trauma resuscitation the term damage control resuscitation, and really that focus was on what was called the lethal trauma triad, or the lethal trauma triad of death, and it encompassed three components. Number one, hypothermia. Number two, acidosis, and then coagulopathies as a result. But in recent years, there's been a lot of focus on a fourth component, and that's where we're going to get into acidosis, hypothermia, coagulopathy, and a new kid on the block, hypocalcemia. This has become a really popular area of focus in trauma resuscitation. A lot of great research has been done on this, really from an observational standpoint only. There definitely needs to be a really definitive randomized control trial that focuses on this. But I think so far, based on the evidence, really physicians are pushing for this treatment in the early stages of resuscitation. And so that is where we're going to focus our attention on, is what that research says, really what the focus is, and how it applies to our ultimate trauma resuscitation. Let's start off with a case. We have a 28-year-old male, 100 kilos, hit by a car. You're called to transfer this patient by helicopter to a level 1 trauma center. Current vitals when you arrive: you have a blood pressure of 88/62, a pulse of 130, and an end-tidal CO2 of 22. And we calculate a shock index, and we have a shock index of 1.4. Now, the key here is a few little things. Number one, the pulse rate really screams at me. Any pulse rate greater than 120 in trauma is telling you are already in a decompensated shock, regardless of a hypotensive blood pressure. So you could be normal tensive. Remember, you have to have a class 3 blood loss over 2 liters to even have any type of blood pressure drop. That's always a late sign. So this patient now has a drop in pressure. End-tidal CO2 of 22 tells us a few things. Number one, most likely is related to perfusion, but it could be based on a minute ventilation issue. We have to look at that. And then obviously these patients in a massive hemorrhage situation, and we're assuming there possibly may be a massive hemorrhage in this patient. Is it an acidosis? And it's unlikely going to be an acidosis to the point of compensation. So I would say this is a perfusion-related end-tidal CO2. The shock index, though, is something that you can use as a tool, and it's very simple. Take the pulse, divide it by the systolic blood pressure. And what I do early in the resuscitation phase is I don't worry about a blood pressure. I will check a radial pulse. If I have a radial pulse, I'm going to use a systolic of 90 as my number. I know that's not a perfect science, and there's some different thoughts on that, but I think it works for me, and it gives me enough of a idea on the standpoint of a shock index that I can make good clinical decisions. So I'm going to just take 130, divide it by that systolic of 88, and we get a 1.4 shock index. Anything that's significant is going to be greater than 0.9. So 0.9 is our threshold. Anything greater than that tells us we have an ominous situation. We have a patient that has a potential decompensation in store for us and future resuscitation efforts. If we continue and look at this patient, physical assessment, secondary assessment, pupils are equal at 3 millimeters. They are sluggish. There has been airway management that has been taken care of. We have a 7.5 ET tube, good end-tidal CO2. Breath sounds, though, are absent on the right, coarse on the left. So we need to look at that a little bit closer. They do have some labs. They have a chemistry panel and ABG. We have a pH right now of 7.21, CO2 of 47, and a bicarb of 16. We have a PaO2 of 88 and a base excess of -9, which would be a base deficit of 9. So at this point, we have an uncompensated metabolic acidosis, or you could really say a partially compensated. Our CO2 is slightly elevated, but that is very borderline. Chemistry, K of 3.6, sodium of 134, mag of 1.9, calcium of 1.1 millimoles per liter. And I specifically put millimoles per liter because there's a few different ways to measure calcium. That's going to give you different types of measurements. Really, in the context of millimoles per liter, a normal calcium is going to be 2.2 to 2.6 millimoles per liter. So a 1.1 calcium is significantly low. We have a BUN of 14 and a creatinine of 0.8. Let's look at their studies. So first off, look at the pelvis. We have 3 compartments we really want to focus on. It's our chest, our abdomen, and our pelvis. Patient was hit by a car. We definitely have significant mechanism. And when we look at this, and I have this area highlighted, we definitely have an open book pelvic fracture. So that open book pelvic fracture is significant. Just imagine all the vessels, all the arteries and veins that line and run through the pelvis. And we should also note at the very top of our pelvic girdle there, if we draw a horizontal line, as you can see here, we definitely have a shearing of the left side of the pelvis. So that is significant. That is a significant injury. Any vertical shear pelvic fracture is a life threat. And we know that the patient can bleed out their entire blood volume in just their pelvis. So we have to take care of this. Now, in early resuscitation efforts, if you are working in the field, any multi-systems trauma patient should be treated as having a pelvic fracture, regardless of your assessment ability. If we don't want to rock the pelvis, you can palpate the pelvis. If the patient is conscious, alert, and able to follow commands, you can have them lift up their legs. If a patient can lift up their legs one at a time, they don't have a pelvic fracture. That's the key. So that is a great rule out for differential diagnosis. Have them lift their legs up. If they can't, possibly have a pelvic fracture. Obviously, you're going to look for femur fractures, deformities in those areas. And if you have deformities in those areas, you're not going to have them do that. But in light of not having any visible deformities, any appearance of fractures in the lower parts of the legs or the femur, absolutely have them try to lift their leg up. Ultimately, though, we want to always just use caution and put a pelvic binder on every single level 1 trauma patient. It really could save their life. It's a cheap, very definitive way of stabilizing that pelvis, and it is significant in slowing down or stopping that bleeding. Let's look at the chest. If we look at and evaluate this patient from a chest x-ray standpoint, remember from a chest x-ray, any x-ray standpoint, if you're looking at the screen, the left side of the screen is the right side of the patient. And we can definitely see our left lung, which is the right side of the screen for you. We have good air movement throughout. We can see we have, good expansion of that chest. We can see the margins. You might have a little bit of a pneumothorax that's appearing. and I'll put this line in right here. But based on your assessment, right, we had coarse lung sounds in the left. I would definitely want to reassess that. But on the right lung, remember the right lung has 3 lobes. You definitely have a diminished or collapsed area. That's probably fluid that you're seeing, and that is encompassing the lower to middle lobe. And so we definitely have to take care of that. So this is likely a hemothorax. We have no lung sounds on that side. That needs to be taken care of. That's a life threat. So based on your ability, this is going to be finger thoracotomy initially, chest tube placement before you leave with this patient. You would not want to leave this patient and transport this patient in this state. Ultimately, it comes down to identifying where that hemorrhage is. And we know that hemorrhage is not always visible. Hemorrhage is going to be hidden. That's where ultrasound-guided therapy and looking at Morrison's pouch and looking at your chest and looking for lung sliding really gives you a really great added way of assessing your patient very rapidly in the field. Ultimately, we have to err on the side of caution and utilize our ability to assess our patients from, again, the standard ways. What's their skin color, temperature? How do they appear to you? Use your gut instinct, shock index, pulse rate, and assume the worst. But we have to stop that hemorrhage. We got to get them to definitive care. The key, though, with the triad of death, or now we're calling it the trauma diamond, is there's secondary life-threatening things that happen during our resuscitation that we have to really guard against. The first one is hypothermia. The next one, as I said, the new kid on the block, is hypocalcemia. And then we have coagulopathy. Ultimately, we have to understand trauma is the start. Then we get to hemorrhage, and that hemorrhage leads to a shock state. That shock state ends up moving into an acidosis. And because we're losing volume, and because of environmental causes, maybe the patient's age adds to this, we become hypothermic, and that leads to coagulopathies. Trauma in itself starts an inflammatory response. We get that surge response. Again, based on that patient's age. Do they have underlying medical issues? Are they on medications? Can they compensate normally? And then how are we resuscitating our patients? Resuscitation adds to this. If we're resuscitating with lots of fluids, normal saline LR, are you diluting this patient? Are you giving this patient cold fluids? So there are so many things that we do, and you could call them iatrogenic, meaning we're causing this. Even though we're trying to do no harm, we cause further injury to the patient. So it's all about understanding resuscitation goals, being very definitive in your actions, and following evidence-based practice. We want to stop the bleeding. Again, as I said, we don't always know where that bleeding's at. This is a great example of a Reboa placed in zone number 3. We don't have Reboa in the field. Very few areas in the United States have Reboa. Hospitals, obviously, level 1 trauma centers, and Reboa is widening in and around the world. But we have to get patients to definitive care to trauma surgeons to where they can intervene in advanced ways. The key for us is to make sure we treat our patients according to evidence. One of the things I think back on is in my early days as an EMT, I became then an intermediate and then a paramedic, is trying to achieve a blood pressure that was normal in these trauma patients. And we've learned obviously a lot over the last 30 years. But the goal for permissive hypotension is to perfuse the kidneys. That is ultimately our goal, our foundational goal. Now there's some added thought processes that go in. Do we have a patient with traumatic brain injury? We know that in those patients, we have to maintain a higher MAP. That MAP needs to be at least 90. And that's because we have to maintain a cerebral perfusion pressure of 70 millimeters of mercury. We assume that every patient has an ICP of at least 20, A lot of the literature says 15. I always round to 20. It's easy, gives me a little bit of a cushion there. And so that gives you a good solid 90. But in most patients, blunt penetrating trauma outside of traumatic brain injury, a MAP of 65 should be our goal. That means you could have a hypotensive patient that is less than 100 systolic that is perfusing enough. And really the thought process, guys, is we don't want to pop a clot. Our body is amazing. And even though we're hemorrhaging out, we have this huge immune response. We have our coagulation factors that are flooding those areas that are injured. And we do start clotting very, very quickly. But is our resuscitation causing more harm? And that's where, again, I go back to my early days where we were flooding our patients with volume. And I think we've seen this in recent years in a lot of different areas of medicine. We've seen it in sepsis. We've seen it in burn patients, where more is not better. We understand much better now that normal saline, although a good fluid, in high volumes can cause a lot of problems. It definitely potentiates acidosis. It definitely causes more harm in large volumes. And remember, when we're giving patients normal saline, even LR, there's no coagulation factors. There's no clotting factors. And that is going to cause problems. Ultimately, packed red blood cells really was the focus in the last 5 years. And there's problems with packed red blood cells as well. We know there's a huge citrate load. We know that there's problems. One of the studies that I want to point out that really focused on component therapy and the benefits was done by a lead researcher, John Holcomb, down in the Houston area. And it was really comparing 1:1:1 versus 1:1:2 ratio. And as you can see, the conclusion, really the benefit was shown in the first 24 hours, but there was no increased survivability at 30 days. But when you compared 1:1:1 versus 1:1:2, again, we're talking about packed red blood cells, platelets, plasma, cryo, etc. There was a benefit in that first 24 hours. And then we saw a trial done specifically called the PROMET trial on FFP. And this was a prospective observational multi-center trial that focused on the effectiveness of treatment with plasma. And really, the conclusion was higher plasma and platelet ratios early in resuscitation were associated with decreased mortality in patients who received transfusions of at least 3 units of blood products during the first 24 hours after admission. Among survivors at 24 hours, the subsequent risk of death by day 30 was not associated with plasma or platelet ratios. So what we're seeing here is very, very similar to the previous trial that we just looked at, is that it's beneficial in the first 24 hours, but it doesn't always translate to 30-day discharge or 30-day survivability. And then we have whole blood, and whole blood has really become a mainstay. Whole blood, we know, is much better. It's all about supply and demand, though, and your ability to store this correctly. The key, though, is to look at this from the standpoint of how good in comparison. And I've got this slide for you to compare. When you look at whole blood, if you give 500 mils of whole blood, you are giving a hematocrit between 38 and 50%. Your coagulation is 100%. Platelets are excellent at 150 to 400,000. And you're giving 1 gram of fibrogen. Your citrate load is much lower. When you compare that to component therapy, packed red blood cells, FFP, platelets, and cryo, you're giving more volume, 680 mils. Hematocrit, though, is much lower at 29%. Coagulation, 65%, actually much lower. Platelets, only 80,000. You're still giving that fibrogen at 1 gram, but your citrate load is massive. So ultimately, whole blood is superior in all counts. One of the areas I want to really focus on is a trial that was done in the Kentucky area. This is courtesy of Aeromethods Kentucky, and I was involved to a point. Really, the lead on this was Kelly Miller. He is currently the VP of Clinical Services for Aeromethods. So all thanks to him and Aeromethods. But this was really our push to get blood on the helicopters in the Kentucky area, and really he led this charge. And so he partnered with the University of Kentucky to be able to look at these patients from transport all the way through their stay. This was in March of 2016, focusing on adult trauma patients. The flight crew had to have 2 consecutive blood pressures of 90 systolic or less. And really, when you looked at this, sample size was very, very small. You can see pre-hospital transfusions 13, flights without blood were 23. What I want to focus on, though, is the data that was extrapolated from this small study. And really, it was to look at base deficit, lactate level, H&H, and was there a significant difference in patients that were transfused. So you can see here over on the right, I have highlighted mortality percentages based on pre-arrival or arrival base deficits. Remember, a base deficit is also a base excess. So for example, if you have a base deficit of 7, as you can see in this area here, that's a negative 7 base excess. So notice in this first area, no blood products whatsoever. Arrival base deficit was 7.28. Pre-receiving center blood was 5.01. If Air Methods transfused the patient, 4.45. Scene flight transfused, so this is earlier intervention, 3.3. So that's a big difference. And then scene flights without. And so notice that scene flights with 3.3, scene flights without 9.37. If you go over to our mortality chart, that is a mortality greater than 23% in those patients. That's pretty significant. So let's look at another data point. When you look at base deficit from the standpoint of research, a base deficit classification for hypovolemic shock was developed on data of 16,000 patients. And really what they looked at was, did it give a prediction? With worsening base deficit, injury severity increased in a stepwise pattern from 19.1 in class 1 to 36.7 in class 4. While mortality increased in parallel from 7.4% to 51.5%. So that is huge. So really, in conclusion, base deficit was superior to current ATLS classifications of hypovolemic shock in identifying the presence of hypovolemic shock and in risk stratification, patients in need for early blood product transfusion. So the key here, guys, is significant differences were seen in this small little trial in both serial lactate and base deficit in the transfused patients, with 64.4% reduction seen with transfused patients. Wow, that's huge. When you look at the arrival H&H, no blood products, we have a 10 and 33. If you look over here at the scene flight transfused, 13 and 40. Scene flights without, 10 and 31. So that's a big difference. Again, big difference with transfused patients versus non-transfused patients. And ultimately, hemoglobin results reflected a 22% increase in hemoglobin concentrations for transfused patients. Now, is that significant? Is that going to improve overall survivability? I don't know. And really, what we've seen in previous blood studies is there is a benefit in the first 24 hours, but from a standpoint of 30-day discharge, a lot of times there's so many other variables in play that doesn't always translate to 30-day discharge with survivability. What about lactate? As you can see, no blood products, lactate of 4.84. When you go over here to the scene flight transfused, 3.9, and then scene flights without, 5.28. And if we go over to our mortality predictor, anything lactate in the 2.4 to 4 range, you have a mortality of 6.4. But boy, once you get above a 4, mortality goes up significantly. And so we know in sepsis, lactate is used in that first hour, probably most beneficial in that first hour to see if you have lactate clearance and what that initial lactate is. But there's a lot of other variables in your treatments, in pharmacology that may change the lactate level and make it go up or down. So really, it's that first initial lactate after that first hour that we look at. And it's all about a stress response. Remember, your liver is responsible for glycogen release. That glycogen release is all about ATP production, and that glycogen converts to glucose through glycogenesis. That glucose goes through the process of ATP production, splits off into pyruvate, goes into the Krebs cycle. We have active transport of hydrogen ions with our B vitamins, niacin, riboflavin, into the electron transport chain, where we have oxidative phosphorylation that happens and ATP is produced. Well, we know that in a stress response, beta-2 receptors, that is exactly what triggers glycogen release from the liver. If we're stressed, we're in a sympathetic surge like these trauma patients are, or any stress response for that matter, you're definitely going to have increased levels of glycogen release, and that ATP production is going to be in overdrive. Glycolysis is going to happen much, much more often. And the thing we have to remember is lactate is produced in aerobic and anaerobic metabolism both. Lactate is a biofuel that our brain, our heart, our different organs utilize as a fuel source. And so lactate is not a bad thing in our normal amounts. Our body uses it. But it's an indicator of a higher stress load, and that is all based on that sympathetic response. Lactate levels showed a corresponding reduction in transfused patients of 26%, and that is huge. And then lastly, our trauma scoring. And really, when we look at this from a pre-hospital standpoint, we don't in the pre-hospital side, from the paramedic EMT side, really look at trauma scoring. We obviously look at Glasgow Coma Scale. And a lot of times our charting will calculate a revised trauma score. This is more used in the trauma centers or in nursing, but there is a corresponding difference when we look at the trauma score and a mortality benefit. So really, from a standpoint of no blood products, our trauma score was 9.83. When we get into the scene flight transfused, trauma score was much lower at 6.6, and scene flights without was 8.6. And so again, there was a significant decrease in trauma scoring. We all saw the CRASH 2 study, and we've talked a lot about CRASH 2. I'm sure you're using your TXA, and we know TXA needs to be given in that first 3 hours of injury. After injury, and TXA is given in a lot of different situations now. It's given in surgery, prophylactically. I know it's reduced transfusions for orthopedic surgeons. It's used in a lot of different ER settings. It's used for nosebleeds. I mean, there's so many different areas of medicine that TXA is being used. But the key is, regardless if you're using blood products, you need to be given your TXA and give it early. Ultimately, though, our focus should be on what are the life threats. And so let's start off with our calcium. Now, when we look at hypocalcemia, obviously, it's based on a few things. Massive hemorrhage, we're bleeding it out onto the sidewalk. Dilution from that resuscitative phase using lots of normal saline or LR. And obviously, the preservatives that we see in packed red blood cells, and even whole blood for that matter, will cause a hypocalcemic state. Not only does it cause all those other issues, it destroys or encapsulates, I should say, 2,3-DPG. 2,3-DPG, if you don't remember, is a molecule attached to every red blood cell. And its sole purpose is to receive a signal. It then communicates with the hemoglobin and offloads oxygen to the tissues that are needing that oxygenation. Well, the citrate encapsulates that 2,3-DPG, and it really causes a left shift on the hemoglobin phenomenon, where we are unable to offload oxygen. The affinity for oxygen to hemoglobin is super high. Now remember, we're giving packed red blood cells, or we're giving whole blood for one reason, that is to increase O2 carrying capacity. And so our hemoglobin is pulling all these O2 molecules. Our seats at the table are all filled up. But because the 2,3-DPG cannot do its job, we have a poor ability to deliver that oxygen to the tissues. So that's just one problem. So giving calcium basically starts unencapsulating that 2,3-DPG. And really, studies have shown it takes 8 to 12 hours before just even half of those are able to be utilized to where you can offload oxygen normally, and maybe up to 24 hours for that to completely unencapsulate and have normal function. Not only that, we've seen in the different trials out there, the ADVERT trial, specifically Dr. Carrie Sims, showed that vasopressin levels were at their lowest based on these massive transfusion protocols. And so what she showed in the AVERT trial was if you have a patient that has over 5 units of overall blood product administration, they were giving a bolus, a 40-unit bolus of vasopressin, and then following that up with a drip at 0.4 units per minute over 48 hours. And they showed benefit. Now, it didn't change 30-day survivability, but there was benefit, and they saw a reduction in overall blood product administration in those patients. One study, Webster et al., noted 55% of trauma patients receiving massive transfusion experienced hypocalcemia. That's huge. A second study showed 97% of trauma patients brought into a UK level 1 trauma center receiving massive transfusion experienced hypocalcemia. So those are huge, huge numbers. Remember, these studies are all observational, though. We need to see a randomized controlled trial that is focused on this topic. In those patients, of the 97%, 71% of those experiencing severe hypocalcemia with ionized calcium of 0.90 millimoles per liter. Remember, a normal calcium measured in millimoles per liter is 2.2 to 2.6. So that is significant. And the thing to understand is clotting cascades are dependent on the ionized calcium. One of the studies that we referenced in the previous slide, Webster et al., noted that once patients began to receive blood products, the incidence and severity of hypocalcemia increased significantly. Pre-transfusion ionized calcium levels were 1.11, again, because they're bleeding out, they're losing that calcium load. But after any amount of blood products administered, 89% were hypocalcemic, with a post-transfusion ionized calcium of 0.98 millimoles per liter. Remember, again, normal is 2.2 to 2.6. So that, again, is significant. So how do we treat these patients? Well, really the evidence, again, when we look at evidence, the highest level evidence is a meta-analysis based on multiple randomized controlled trials. The next step down from that are standard RCTs, randomized controlled trials. The evidence that we're seeing here with the trauma diamond and the hypocalcemia and treating that is observational only and expert opinion based on different physicians around the world. And really the I think consensus is this: 1 amp of calcium chloride after that first unit of blood product. Now remember, calcium chloride can cause major issues if you infiltrate. So always make sure you have a good large bore patent IV. A lot of physicians out there, I know, really push saying any calcium chloride administration needs to be through a central line, but we don't always have that capability. And so some EMS agencies have gone to calcium gluconate. If you have calcium gluconate on your rigs or your helicopters, it's 3 amps of calcium gluconate to 1 amp of calcium chloride. So you would give 3 amps of gluconate after that first unit of blood product. And really then when you get into the secondary calcium administration, it comes down to time. How much time do you have here with your patient? Are you in a situation where you have long transport times? We teach all over the world, and I meet people that have 5-minute transport times. I have crews in Alaska, in the areas of Colorado, that have 2-hour, 3-hour transport times. And so it all is going to be based on where you're at. But really secondary calcium given after the second or fourth unit. Again, the opinions on when to give that second amp of calcium is really varying. Some say after the second unit, some say after the fourth unit. Ultimately, your medical director needs to make the decision, and it's going to come down to how much time you have with your patient. Ultimately, if you have the ability to do point-of-care testing at the bedside, do you have an iStat with you that you can do these ionized calcium tests? The treatment should be to maintain ionized calcium levels greater than 1.20. So anytime you have that drop below the 1.20 millimoles per liter, you need to be treating with more calcium. Again, as I said, 1 amp of calcium chloride is equal to 3 amps of calcium gluconate. How do we focus our attention on correct treatment for trauma patients? And what I mean by that is I see this mistake constantly. We forget that our patients are potentially cold. Even if ambient temperatures are super hot, you're sweating. Doesn't mean your patient is not ice cold. It comes down to understanding What's the age of your patient? Remember, pediatrics, elderly patients have a very poor ability to regulate their temperature. They have a non-regulatory hypothalamus at this point. So don't rely on specifically the time of year. Every patient should be deemed cold, every one of them. On the aircraft, you should have your full winter blanket on every trauma patient. And that's the key. And really, the greatest contributor to hypothermia is room temperature and fluid administration. Are you warming your fluid? Are you putting your fluid in those fluid warmers even in the summertime? What about winter areas? I mean, areas that up in the north, in Minnesota, Wisconsin, Alaska, Canada, that get negative 40, 50 degrees. You need to make sure you have fluid warmers. Are you putting cold blood in, or are you using some type of warming device that flash heats that blood or that fluid before putting it in? That is so big in resuscitation relative to that trauma diamond. Is your trauma bay warmed up? Well, yeah, most level 1 trauma centers that I've been to are warmed up, but I have seen over and over and over patients with their clothes completely stripped off naked, and they're laying there for the world to see. They're not covered up. Everybody's around them, and they're ice cold. So we have to really be careful, and we see this out in the pre-hospital setting. Get your ambulance warmed up. Understand, even if you're hot, your patient is laying on possibly on a long spine board, they're going to be ice cold, and their ability to regulate their temperature at that point is going to be depleted. This is a great example of the military doing a great job, and I think we've seen that in the Iraq conflict, where soldiers were delivered constantly to these battle hospitals, even with ambient temperatures 120, 130 degrees Fahrenheit, hypothermic, because we assume the ambient temperature being that warm that nobody could get cold. And so that's the key. We've learned so much from those military conflicts. Ultimately, we got to maintain normothermia as best we can, and that requires ATP. And so we have to remember that we're already in a shock state. We're already in a severe sympathetic response. These patients are fighting for their lives. If you then put them into a state where they're shivering, they're now burning through more glycogen stores, they have to have those glycogen stores to produce ATP, and you're just causing a shock state, which is going to potentiate anaerobic respiration, which is going to potentiate more acidemia, and that is another key ingredient to that trauma diamond. Ultimately, our delivery of oxygen, this formula here at the bottom, DO2, the delivery of oxygen every minute, is equal to the content of oxygen in our arterial blood, CaO2, times Q. Q is our cardiac output. So we've got to be able to deliver it with a correct minute ventilation. We have to make sure we're optimizing that oxygenation phase. We also have to understand that the perfusion side has to be taken care of. And that's where we always come back to the foundation, the shock state. Are you fixing the shock state? You take one area at a time. Take care of airway, breathing, then focus on circulation, and make sure you're optimizing each part of that. But don't forget the small little things of maintaining that normothermia, maintaining a patient in a state to where they're warm. And that really will add to your ability to turn around a negative shock state. What about our coagulopathies? Coagulopathies are huge. We're already starting, we're bleeding out, we're hemorrhaging, we're losing all those clotting factors. We're then diluting our clotting factors. We're becoming hypocalcemic, which is inhibiting our coagulation factors. And so the key is getting in front of it. And it comes down to stopping the bleeding, getting in front of the acidemia. Look at this. A pH drop from 7.4, which is normal, to 7.0 decreases our coagulation cascade effectiveness by 70% at the maximum. That is massive. So again, comes back to early recognition, airway management, optimizing oxygenation, really getting in front of sedation and pain management, and getting in front of those areas that we can control, keeping them warm, keeping them quiet, keeping them still, stopping that hemorrhage, and getting them to definitive care. Remember, calcium helps activate coagulation factors. in the clotting cascade. Can't forget that. It's also temperature dependent, and it causes that platelet sequestrian, right? We want all those platelets to come together. We want that platelet mesh to happen. But having a hypothermic patient, having a patient that's already hypocalcemic, causes this to stop or slow down. Ultimately, guys, in summary, we have to stop the bleeding. We have to recognize those 3 life threat areas: our chest, our abdomen, our pelvis. Do the little things. Put pelvic binders on. Listen to lung sounds. Understand mechanism. Understand permissive hypotension. A MAP of 65 is all we need. Level 1 trauma centers all over the country are actually treating patients with blunt or penetrating trauma outside of traumatic brain injury at MAPs as low as 50, just to get them to the OR so they don't pop those clots, so they don't worsen that bleeding or that hemorrhage. Volume replacement, if possible, should start with whole blood packed red blood cells. Obviously, component therapy of the 1-to-1-to-1 is optimal. Most pre-hospital providers will have packed red blood cells or FFP if you're carrying component therapy. And a lot now are going to that whole blood. If you don't have that capability, just remember, you don't have to slam liter and liter of fluid in these patients. Sometimes it's best to just limit that. Focus on a MAP of 65. Don't look at the blood pressure from any other standpoint, even if your systolic is less than 100. As long as that MAP is 60-65, I am golden. Heat loss drives the triad. Can't forget that. That's something that's very easily taken care of. Warm your patients, warm your fluids, make sure your blood products are pre-warmed before you put it in. And then remember the new kid on the block, that we have to replace that calcium. And really, I've been pushing this on podcasts for quite a few years. In a trauma setting, in a patient that is in a shock state, their blood pressure is hypotensive, heart rate is up, shock index is up, it is always a good thing to give an amp of calcium. You're never wrong to go that route. I think it optimizes that cardiac contractility. Obviously, muscle contraction, vascular tone improves, and blood pressures will potentially improve as well. If you have any questions on this, please email me at eric.bauer@flabberjet.com, and I will talk to you soon.
Hi, Marty. How you doing?
Well, thank you, David.
Can I take this opportunity to thank our presenters and to thank our attendees and our sponsor for this webinar as well, of course. Hi, Eric. Can you hear us now? Marty, from your perspective, how does Eric's presentation reflect current practice in New South Wales Ambulance?
Yeah, thanks, David. Look, I think Eric's presentation very much aligns with our delivery of critical care, not only in New South Wales, but around Australia and New Zealand, particularly in the, but probably in the aeromedical setting, settings where we do have access to point of care tests, where we do have access to a variety of blood products. I think there's great alignment there. I think, and definitely the principles in which he was working through, aligned to my experience. And again, the changes of that experience in recent years as the evidence base develops. I think the challenge that probably most of the Australian, New Zealand viewers have is that we don't have access, generally speaking, to blood products outside of the aeromedical setting in this context. And point of care testing has probably had more use to date, probably in the extended care paramedicine space, apart from a few small areas that have used it in the critical care space around Australia, New Zealand. I'm hoping we get Eric back to be able to talk in a moment, David, because I'm actually quite interested in that, which parts of we could use to improve our care in the short term. And I think one of his last comments was quite interesting about administration of an amp of calcium chloride or 3 amps of calcium gluconate, and that's definitely something that there's been discussion on in my setting of late, and very much flowed on from the military use of calcium as well. So it's always good when an old medication gets a new use.
Yeah, absolutely. And that was going to be one of my questions actually, is what is the current practice in Australia and New Zealand in regards to giving calcium with blood and during whole blood transfusions? Because I don't think it's commonplace at all at this stage, is it?
So in the settings I've worked in, it's definitely been the case for probably about the last 8 years or so that calcium is administered when we commence peripheral blood transfusions in my HEM service, and very much in line with the comments that Eric put forward. So we'll quite often start give the first calcium with the first unit of blood, and then repeat, pragmatically, as he put forward, with every 2 to 4 units, if you're just going off some clinical NOUST or make use of point of care testing if it is available.
Yeah, I was really interested in the summary, particularly in regards to hypothermia and heat loss driving the triad of death. It's something I think we try not to overlook, but it's easily overlooked.
Yeah, and I think Eric made some very valid points, and I think the basics done well can sometimes be the aspects overlooked, and obviously we need to warm our patients up with blankets, absolutely. A number of services these days looking at chemically heated blankets to help as well. But, really a situation as well where you've got to be mindful of all the different ways in which you can have heat loss. And unfortunately, when our patients remain on the ground for too long, quite often it's that conductive loss into the ground that can be the problem. So, it's a situation where, rapidly getting them onto our stretcher and potentially into the back of our ambulance to perform our meaningful interventions there can be beneficial for multiple facets. But I also agree with his comments of covering the patient up, because as well as heat loss into the ground through conductive loss, we've got to be mindful of that, of convection as well, and, the wind blowing past the patient once we've exposed them. So.
Absolutely. And there's a couple of questions in our chat that kind of relate to that, and I think we've answered those, but it is an interesting area for sure. I know our services have talked about REBOA in the past. It's something I think a number of services would like to do. Is there any movement in that space, to your knowledge, Marty?
Yeah, again, in the higher level critical care team situation, it's continually looked at and investigated. I know in New South Wales, the medical teams have looked at it.
Marty, just reflecting on that presentation, we're getting close to the end of this webinar. Where do you see the future, the application of this trauma diamond going in the Australian New Zealand services?
Yeah, look, I think very much following along the line of our colleagues around the globe. I think it really does reinforce some of those factors we've considered for decades now. Really reinforces that we have to get the basics done well before we move forward. We need that great environmental control of the patient. We need to be able to stop the bleeding with whatever devices we have. Become aware of what the patient's current clinical status is and what their predicted injuries and injury patterns are going to be. And then obviously, at the moment, either be prepared to provide that care yourself or get that care coming to you if you need to care for other resources. And then, reinforcing that fact that we've had in place for decades in Australia and New Zealand about getting these patients to the right centres, to the right hospitals the first time. And then I think, the interesting aspects for us around some of the more the IV aspects is that, does calcium play a role, even if you're in a service that doesn't have pre-hospital blood products in the coming years? I think that's an interesting one, and it's unfortunate we can't explore that further with Eric at the moment. But, TXA as well, its use. There's probably a split between the jurisdictional ambulance services in Australia and New Zealand about those who are using it currently and those who are waiting for the patch trial to publish their results at the end of this year. I know in my context, New South Wales Ambulance was a participant in the patch trial, and we're waiting for the results of that trial prior to making a decision about implementing TXA or not. But again, another intervention that for very low cost potentially can have some positive patient outcomes.
Great, thanks, Marty. A fascinating topic, an amazing presentation by Eric. Unfortunately, Eric can't get back online with us. So look, Eric, if you can hear us, thank you very much. I know many of our participants really enjoyed it by the quality of the questions in the chat. Certainly the technical level of the presentation was spot on. Some great questions. As you would have seen at the end of the presentation, Eric did leave his email address for people who did want to catch up with him or send a question to him personally. He's very generous with his time. I'm sure he'll respond. Marty, thank you for jumping in. And for those who are watching and attending the CAA Congress in a couple of weeks, Marty's presenting at that. So come along and we welcome you. Again, thanks everyone for participating. Sorry about those couple of technical glitches. Sometimes we just can't control all of those. Just a reminder that our next webinar at the end of August, 30th of August, is on the subject of mental health and well-being for our workforce, and that's sponsored by Evermind. I encourage you to jump on, register now, and that's in your diary ready to go. So again, thank you to Zol and the Zol team for supporting us. Thank you to the presenters, and thanks to the audience. And we look forward to seeing you again soon on the next CAA webinar.
Thank you for attending Aeromedical Retrieval Complexities, the Trauma Diamond, presented by Eric Bauer with Q&A with Eric Bauer and Marty Nichols, proudly supported by Zol. Join us for our next webinar on Tuesday, August 30 at 11 a.m. for mental health and well-being, supported by Evermind. You can view all of our upcoming webinars by visiting www.caa.net.au/webinars. And be sure to follow us on social media to keep up to date. Twitter @CAA Australasia, Facebook and LinkedIn, the Council of Ambulance Authorities Australasia. Thanks for joining us, and we'll see you next time.